Right, that's recording now, Linda.
Perfect, thank you. Good afternoon, everybody. My name's Linda Dunn. I'm a stroke nurse consultant at East Lancs Teaching Hospital. And the session today is around BEFAST, so it's expanding the stroke recognition beyond our usual FAST. Sorry, my computer's doing something. I'm not even touching it. Right, just a little bit of housekeeping, please. If you can keep your video on, because it's quite nice actually to see your face rather than just a blank screen when you're presenting. If you can keep your microphone on mute, that would be appreciated. If you can just enter your name and job role and place the work in the chat just to give me some idea of who's on the session and tell us what your goals are for this training. I would ask if you've got any questions, if we can just use the chat function and review that at the end. There is a component at the end where you'll be asked to contribute to some clinical scenarios, and that's using a QR code on your phone. Just have those ready towards the end. And just to say that the session has been recorded today for those who can't attend this training, so it can be accessed again in the future. So who's this training for? Well, basically a stroke can happen to anyone, anywhere, not just in the clinical areas. Symptoms can be sudden and obvious, or they can be subtle and easily missed. So every single member of staff in our organisations has a role to play in recognising possible stroke and escalating those symptoms quickly. For the learning objectives, by the end of this session, you'll have knowledge and confidence to recognise the signs and symptoms of stroke and transient ischemic attack. You'll be able to apply the BEFAST stroke assessment to your day-to-day practice, regardless of what your role or clinical background is, and that will ensure that we've got a consistent and shared approach to stroke recognition across our organisations. The session also aims to identify red flag stroke presentations that require urgent action, helping to reduce delays in escalation and treatment. You'll also gain clarity on when and how to refer appropriately and understand the importance of rapid communication with the stroke team. And finally, the sessions will reinforce why early recognition is vital, highlighting the impact of timely identification and referral to the stroke team, because it saves lives and reduces long-term disability. So why is more training necessary? Many stroke patients do actually arrive to our emergency departments by ambulance, where an alert is raised immediately and pathways are already firmly in place. In these situations, what we find is that stroke is recognised and the response is swift. However, not all of our strokes present in that way. Some patients walk into the department by themselves and may first speak to the emergency department reception staff. And others may experience the stroke symptoms anywhere in our organisation, and I'm sure we've all had experience of this in outpatient areas, corridors, waiting rooms, communal spaces like the coffee shop, or anything like that. In these moments, there's
Linda, sorry to interrupt you. Your slide hasn't moved on from the opening slide.
What has on mine?
Yeah, no, it's not done on the for some reason. So it's still on the first slide.
Let me share it again.
Okay. Yeah, it's moving on now. And you're on mute, sorry.
Sorry, we've definitely got gremlins in the system
Yeah.
today. A little bit of user error as well. So just going back to why more training is necessary, I think I've just explained there that stroke can happen anywhere in our department, and it's really important that we all have tools to be able to recognise those symptoms. Many of us have found people with stroke in places like waiting rooms, coffee shops, you know, in our outpatients department, cath labs, wherever in the within the organisation. So it's essential that we have tools for prompt recognition of stroke symptoms. The evidence consistently shows that early identification and rapid escalation does reduce mortality and prevent any significantly limiting life-changing disabilities. The research also shows that the reception and frontline staff are really, really good at recognising common symptoms of stroke, such as the facial weakness, slurred speech and arm weakness, but the less common symptoms or atypical symptoms, such as atypical, such as things like visual disturbance, balance problems, confusion, sudden changes in behaviour, can be much harder to identify and are often missed. This is why the training is essential, because stroke is everyone's responsibility. It's not just for the doctors and nurses. It's our reception staff, porters, admin teams, allied health professionals. They might be the first point of contact. So the aim is that identification of these less common symptoms using BEFAST will help us to identify strokes better in future. So, stroke remains a major health challenge in the UK, with over 100,000 people a year in the UK is having a stroke. It's one of the leading causes of death and disability, as we know. It affects not only the patients, but the families. It affects our healthcare services, our society as a whole. When a stroke happens, we lose 1.9 million brain cells or neurons every minute. That treatment's delayed. And this rapid and irreversible damage is why stroke's described in some countries as a brain attack, like a heart attack, and that kind of emphasises the emergency response that's needed. The longer a stroke goes unrecognised, the worse the outcome. So delays in recognition and treatment significantly increase the risk of death, disability, long-term dependence on care. And in addition to the personal impact, stroke pays a substantial financial burden to the economy, and that's in direct costs to our NHS and wider costs to the country as a whole. The positive message is that stroke outcomes can be improved. So prompt recognition of symptoms and immediate referral to the specialist strokes team saves lives, reduces disability, limits long-term consequences of the stroke, and early action truly does make change in impairments. So this is why stroke recognition by all staff in all settings is so important, because every second matters. So just because this session was originally designed for our ED receptionists and triage staff, I thought it was important just to very, very briefly explain what a stroke is, in case we've got that group of people on this call. So stroke is a sudden medical emergency that happens when the blood supply to parts of the brain are interrupted, usually by a blocked or burst blood vessel. When this happens, brain tissue is deprived of oxygen and nutrients, and brain cells begin to die within minutes. There are two types of stroke. The most common is an ischemic stroke, which occurs when a blood vessel supplying the brain becomes blocked, usually by a clot. The second is a hemorrhagic stroke. This happens when a blood vessel bursts or ruptures and causes bleeding in and around the brain. We also hear of the term TIA, or transient ischemic attack. Some people might have heard that described as a mini stroke. In TIA, the symptoms totally resolve, but it is a serious warning that a full stroke might follow. The key message again is that stroke is time critical. The longer the brain's without blood flow, the greater the damage and the worse the effects are on the body. So this picture here, as that picture come up, there it is. That picture there is just a visual representation of what I've already said. Ischemic strokes are strokes caused by blockage occurred by account for 85% of our strokes, and hemorrhagic strokes account for 15%. Why is stroke identification of stroke so important? And it comes down to treatment. The aim of the game for us is reperfusion. This means restoring blood flow to the brain when the stroke is caused by a clot. The sooner the blood flow is restored, the more the brain tissue can be saved. And this is a picture of what we call a tip perfusion scan. It shows the red in the area shows what we call the ischemic core. That's the area that's damaged by the stroke. But the green area around the outside is tissue that is still viable but at risk of dying if we don't intervene with any reperfusion treatments. I should also add, which I didn't put a slide in, I'm sorry, if a patient has a intracerebral hemorrhage or a bleed in the brain, we also have pathways to reduce disability and mortality. We use the ABC-ICH protocol to initiate some early blood pressure management, reversal of anticoagulation, and referral through to our neurosurgical colleagues if it's deemed appropriate. So it's important to know that we have paths for both types of stroke for immediate intervention. So the first option that we've got in terms of reperfusion is thrombolysis. It's clot busting treatment. We use a medication called primarily now tenecteplase, but our backup is alteplase. It's a tissue plasminogen activator. It's given through the vein, and it basically breaks down the fibrin in the clots. The most effective treatment is given within 4.5 hours of symptom onset. So the referral time and recognition of the symptoms is vital. But there are some sort of circumstances where we can give up to 9 hours now with the aid of our advanced imaging. If the stroke isn't recognised, and this is really important, then the patient might just arrive too late for any treatment with thrombolysis, or if they've been sat in the waiting room for very long periods, like we know can happen, particularly with our self-presenting patients. The second option that we have for reperfusion is thrombectomy. This is a treatment that which it physically removes a clot from the brain. It involves putting usually a mesh device into the artery in the groin, moving it up to the brain and physically pulling out the clot. It only works for people, sorry, it doesn't only work, but the only people who are eligible are people who've got a clot in the large vessels in the brain, and that is about 30 to 40% of our strokes are thought to have a large vessel occlusion. Obviously, not all of them are eligible for treatment. There is a strict criteria which we have to adhere to. Historically, however, only a small proportion of stroke cases were eligible for thrombectomy, and treatment needed to be given within 6 hours. Thrombectomy can be life-changing. I mean, these are the strokes that come in really disabled and can often now walk out of the hospital in just a few days with this treatment. It's been a real game changer for us within the stroke world. In addition to a plain CT scan, however, a CT angiogram is also necessary to identify the large vessel clot. So this is just a picture of what the CT angiogram looks like. This is the circle of Willis here. And you can see on this side, you can't see my arrow, can you? No. No.
Yeah, we can
so
see your arrow.
You can see my arrow. So you've got a complete middle cerebral artery there on the right, and on the left there you can see there's a blockage, and that vessel has it's blocked. There's no perfusion beyond that clot. So that's essentially what it shows us. So in terms of advanced imaging, with the aid of our CT perfusion scan, and there are occasions now where we can consider clot retrieval up to 24 hours. So it's really important that when a patient comes in and they say they've had symptoms, that you do refer them, because we're assessing everybody now for eligibility for one of these reperfusion therapies. It's important to determine the times the symptoms were first started and when they were last seen well. And the CT perfusion scan tells us the extent of the stroke damage and whether there's enough brain tissue still to be saved to warrant the surgical intervention, which is what that picture does show there now. The red is damaged tissue, the green is salvageable tissue. And I think the other important message to get across at this point in time for our reception and triage nurses is there is an awful lot of stuff that needs doing to get the patient to the point of these scans. We need to get them in. We need to do an assessment using our National Institute stroke scale. We need to be cannulating, taking bloods, checking vital signs, requesting those CTs and escorting them around to the scan. And our door to CT scan is now less than 20 minutes. So if you factor that in, that rapid referral is essential. So this is the FAST campaign. We're all very familiar with this. It was introduced originally as a memorable tool to help the public and healthcare staff to quickly recognise the most common signs of stroke. It was widely promoted in the UK in about the late 2000s, I think, and it was led by the Stroke Association and the NHS. The aim of FAST is absolutely clear. It's to make stroke recognition quick, accessible and actionable for people without clinical training for everybody. So by focusing on 3 observable signs, the face weakness, the arm weakness and the speech disturbance, we've helped to critical message that time is critical. The final letter T emphasised the urgency for immediate action. If any FAST symptom is present, urgent referral or emergency response is required, as delays can significantly worsen outcomes. So in addition to these 3 symptoms highlighted in FAST, there are several other common symptoms of and signs of stroke. These can include weakness, numbness on one side of the body. It might include the leg, which isn't included in FAST because it was originally designed to assess a patient when they sat down. It doesn't involve the hand or foot either. Patients might have difficulty finding words or speaking clearly. They might have difficulty saying meaningful sentences, so they might be able to say odd words, but they definitely won't be able to speak a sentence and they might not understand language. They might have sudden blurred vision, loss of sight in one or both eyes. That's another warning sign. And they might also have memory loss, confusion. So particularly when symptoms are abrupt and unexplained, that's when we need to be concerned that this might be a stroke. We also have symptoms such as dizziness, unsteadiness, or an unexpected fall, which can be a key presentation. Often a patient will stand up and their legs give them way, and they'll come in as a fall, but actually when we interrogate, we find that they've fallen because they've had a weakness. So any of those symptoms should prompt an urgent referral through to us as the stroke team. So we've established that it's a simple, rapid and easy to remember tool, which is great. It means it's really ideally suited for those non-clinical staff. One of its greatest strengths, though, is that it can be applied within minutes, well, seconds even, without the need for specialist equipment or advanced training. And it allows the common symptoms of stroke to be identified at that very first point of contact. FAST has been shown to have really good sensitivity for common anterior circulation strokes, which are those strokes at the front of the brain that have the types of common symptoms that we've mentioned. Research demonstrates that sensitivity rates range from 64 to 97% and highlight its reliability in identifying patients who require urgent assessment and escalation. This is further supported by a large-scale meta-analysis data showing that combined sensitivity is 0.77, and it confirms that FAST is an effective first-line screening tool for stroke recognition. In addition, FAST is really well embedded within our emergency and ambulance services and within the general public. And it's, over the years, it's been firmly integrated to our stroke pathways. Its widespread consistent use across healthcare settings supports rapid escalation, clear communication, timely access to specialist stroke care, and helps to minimise any delays in treatment. While FAST does not capture every possible stroke presentation, its simplicity has proven its effectiveness, and it's made it the cornerstone of early stroke recognition historically. But while it's a valuable tool, it does have important limitations that we need to understand. It has low and variable specificity, ranging from 13 to 76%, which means it can create some false positives. This may increase urgent referrals. It can also place pressure on services and highlights the need for clinical judgment alongside screening tools. More importantly, FAST is known to miss the posterior circulation strokes. These are the strokes that often present with symptoms such as imbalance, dizziness, visual disturbance, none of which are assessed on the FAST criteria. As a result, patients with these presentations may appear well or as a non-stroke at first contact and can be missed. It's suggested that actually 14% of ischemic strokes may be missed when using FAST alone. And it's particularly those that have posterior circulation symptoms. The posterior circulation strokes present a particular challenge in stroke recognition, and I think all of us working in stroke have found that tricky at times. These strokes affect the brainstem, cerebellum, occipital lobes, and the symptoms often differ significantly from the classic stroke signs, which people are more familiar with. Unlike anterior circulation strokes, posterior strokes frequently do not cause obvious facial droop, arm weakness, speech disturbance. However, it is worth noting that sometimes they can have those as well. It might present with sudden dizziness, imbalance, visual disturbance, nausea, vomiting, altered consciousness. The symptoms can actually be vague and transient, and that makes it even more tricky, and can be attributed to less serious causes such as inner ear problems, migraines, infection, anxiety, which means that our posterior circulation strokes are more likely to be missed or misdiagnosed, particularly at that first point of contact. Patients might be able to speak well, clearly, have no obvious weakness, which can give us a false reassurance and delay our escalation processes. So while traditional tools such as FAST are highly effective for anterior circulation strokes, they don't assess balance of vision, meaning posterior strokes can fall outside its scope. This has been consistently highlighted in the research, which shows that posterior strokes are disproportionately under-recognised and experience longer delays in diagnosis to diagnosis and treatment. This leads to poorer outcomes. So this is the recognition. There was a recognition that there was a gap, and this is why expanded tools like BEFAST were important. By deliberately including things like balance and eyes, it prompted staff to consider stroke when patients present with sudden unexplained dizziness, coordination problems, and visual changes, symptoms that should never be dismissed or ignored in healthcare settings. So improving recognition of posterior circulation stroke requires education, awareness, confidence across all staff groups. So while we understand that stroke is embedded and used well, we understand that it's no longer enough to identify those posterior circulation strokes. The key message is simple: a FAST negative patient can still be having a stroke, but recognising these symptoms is critical to improving their outcomes. So just in terms of red flags, these are some of the red flags for brainstem strokes. It can include things like dysphagia, which is swallowing problems, dysarthria, slurred speech, or unclear speech. Hoarseness can indicate involvement of the lower cranial nerves and shouldn't be overlooked. Reduced level of consciousness is particularly concerning, as it suggests that the brainstem or reticular activating system is involved. We may also see cross signs, such as facial weakness on one side, with limb weakness on the opposite side, which are classic for brainstem pathology. In rare but devastating cases, patients might present with features of locked-in syndrome, where they're conscious but unable to speak or move. This is an emergency situation, as is any patient with a sudden drop in GCS combined with abnormal pupils. They should all be treated as a neurological emergency and escalated immediately. And I still find, despite using the tools that we currently do, that these patients often come in with a low GCS and we get delayed late. They get referred to us late because they think something else is going on. So enter BEFAST. So BEFAST helps to build on FAST. It helps us to recognise a wider spectrum of stroke presentations, particularly the posterior circulation strokes. B's for balance, identifying sudden problems with balance and coordination. E is for eyes, focusing on sudden visual changes such as loss of or double vision. And F, A and S all remain the same. T still reminds us that stroke is time critical and that rapid recognition and escalation can be life-saving. So just looking at the evidence, sorry, just excuse me while I have a drink, I'm going croaky. But the evidence from multiple observational studies and a meta-analysis done by Chen, I think it was 2022, shows that BEFAST improves overall stroke detection, particularly when it's compared to FAST alone. By expanding assessments to include balance and eyes, BEFAST increases sensitivity and helps capture stroke presentations that might be otherwise missed. One of the key strengths of BEFAST is its ability to reduce missed posterior circulation strokes. Studies do show, however, a slight reduction in specificity, meaning that there might be more false positives. However, in our practice here at East Lancs, we've accepted this as an acceptable and necessary trade-off in terms of identifying time-critical emergency stroke presentations, where the risk of missing a diagnosis far outweighs the overall impact. Systematic reviews consistently highlight that posterior circulation strokes are frequently under-recognised, particularly at the first point of contact. BEFAST directly addresses this gap, providing a broader, more inclusive screening approach. Overall, the evidence supports BEFAST as a more comprehensive frontline tool for recognising posterior circulation strokes. So we at East Lancs anecdotally identified that we were missing a lot of posterior circulation stroke presentations. So we decided to do an audit, which was retrospective. We looked at a period of 3 months from January to March 2021 of patients who self-presented to the emergency department with stroke, with confirmed stroke. There were 44 patients over a 3-month period. Using the traditional FAST assessment, only 61% of these patients had symptoms which would have been recognised as a stroke. However, when the broader BEFAST criteria was applied, symptom recognition increased significantly to 84%. Importantly, BEFAST would have identified stroke symptoms in an additional 37% of patients who were not captured by FAST alone. These findings highlighted the limitations of FAST for us in isolation and demonstrated the potential benefit of us adopting BEFAST to improve early stroke recognition for those posterior circulation strokes, which was ultimately our area of concern. So just looking a little bit more closely at the two new elements. So when we consider the balance component of BEFAST, it's important to recognise that this is just not about asking whether the patient feels dizzy, which is what we've found can happen, and we get lots of dizzy patients with no other neurological deficits referred through to us. Dizziness alone is a non-specific symptom, and it's very common. What we're trying to identify is a sudden change in balance or coordination. This includes vertigo where the room feels like it's spinning, but also difficulty standing and walking, feeling like they've been pulled to one side, noticing that the body's swaying or leaning, or that they're unable to sit upright without support or walk, staggering gait. And these symptoms point more towards a posterior circulation stroke. But just building on balance, we also need to consider any sudden loss of coordination, which can be subtle and highly significant. We should ask whether the patient's arms and legs feel clumsy or uncoordinated. Movements might feel jerky, poorly controlled or unfamiliar to the patient. I've moved on too far. No, I haven't. Keep going. These changes can represent cerebellar involvement and might occur without obvious weakness, meaning that they can be overlooked. I think we need to work on the principle that sudden balance disturbance is a stroke until it's proven otherwise, especially if it's associated with eye symptoms, nausea and vomiting, slurred speech, new headaches. In terms of eyes, what are we looking for? So the next step would be to ask clear focused questions about vision. We want to know whether there's been any sudden changes rather than long-standing or fluctuating problems. We need to ask if the patient's vision has suddenly changed. It helps open the conversation, followed by checking whether they can see normally out of both eyes. We should also ask directly about double vision or difficulty focusing. Patients often don't volunteer these symptoms unless they're prompted. And these targeted questions help to uncover visual symptoms that strongly support a diagnosis of stroke and ensure that they're not overlooked. There's some questions there. Has your vision suddenly changed? Can you see out of both eyes normally? Are you seeing double or struggling to focus? So, as part of the implementation process in East Lancashire, East Lancashire, to help our practitioners to implement the BEFAST, we developed a stroke rapid assessment triage checklist. And I don't know how big that is on the screen and whether you can see the details of it, but it just gives some indicators in terms of symptoms that they would expect to see within each of those fields of the BEFAST test. What it did, we don't use it now, but what it did do was increase confidence amongst clinicians, and it just helped them to understand the process better. There was some pooled data for other tests as well, which I've captured there. We've got the FAST test, which improves detection of posterior strokes. Sorry, we haven't. We've got FAST, which misses posterior strokes. We've got BEFAST that does improve detection of posterior strokes, but has a limited evidence base. We've got Rosier, which is recorded as the best overall in terms of accuracy, but this is more of a diagnostic tool that we use once the patient has entered the emergency department rather than the first point of contact assessment. There are other tests such as the LA, so the Los Angeles stroke scale and the Melbourne stroke scale. The LA version has high specificity and misses a lot of cases. The Melbourne one, while it's got a balanced performance, it's not really very well used in practice, and some of my colleagues, senior colleagues, hadn't even heard of it. So that just shows that. Just to show you the Rosier and what that looks like. I'm just going to move on my other screen because I can't see it on this one. If you just bear with us. Sorry, I can see that now. So you can see on the Rosier test, we're asking for somebody who would have some clinical knowledge. Have they had loss of consciousness, syncope? Has there been some seizure activity? And then there's a bit more of an extended assessment in terms it's a bit more in depth than FAST because it includes visual field defect. A score of 0 or equal greater than 0 means that stroke's likely. A score of less than 0 or equal to 0 means that stroke is unlikely, but it's not completely excluded, so it doesn't give us a definitive answer. But what it does help us do is exclude some stroke mimics. It gives the confidence to the emergency department team to do that. If you look at the LAPS and the MAS, again, this is more of a tool that needs delivering by a clinician, because we're asking for more information. We're asking about blood glucose levels. We're asking about whether they've had any seizures, what the baseline premorbid function was, etc. So it's not easily administered as a first-line test. And I think that is about it. What I have done is I've done a couple of case reviews for everybody to go through, if you wouldn't mind. So if you can open your phones to camera and just point the camera to the QR code, should give you the option to answer these questions as we're going through. I'll give you a few minutes just to do that. Just give us a few thumbs up if people have managed to get that up. Still see a few people struggling there. I'll give you another minute or so. Okay, I think I've got a few now. You can catch up if you want to. Just see how we go. So the first patient is a 59-year-old female. She was witnessed to have a sudden onset of right-sided face, arm and leg weakness. She's got some expressive speech problems and slurred speech. The symptoms happened 90 minutes prior to arrival. So within your Microsoft Forms, if you can just apply the FAST test and then apply the BEFAST test for that patient. Okay. So for this patient, it's pretty straightforward. She only meets the components of FAST. She's positive for face, arm and speech. BEFAST doesn't make any difference for this patient. So the patient, regardless of which tool you used, has been identified as a stroke and referred through to the stroke team. So it wouldn't have mattered in this case. This is a typical anterior circulation stroke presentation. So the outcome for this patient. Oops. She had a CT and a CT angiogram. It confirmed a stroke in the left middle cerebral artery. She was thrombolyzed with tenecteplase, transferred to the tertiary centre for thrombectomy, and was discharged from hospital on day 4 with a mild arm weakness to community therapy. Post-rehabilitation, she was living a full and independent life with an almost total recovery. So early identification for this patient meant that she could receive all of the reperfusion treatment that she needed, and she went on to live that independent life. Clinical scenario 2, if you want to answer that on your form, is a 37-year-old man suddenly develops double vision, vertigo, which is dizziness, and is unable to walk in a straight line. He collapses when he's walking out of the gym before he arrives at the hospital. So again, apply FAST and then apply BEFAST. So this is a breakdown again of the assessment. If you've just applied FAST, the patient has no symptoms and the stroke would not have been identified and they wouldn't have been referred to the stroke team. Sorry, there's an error on there. If you'd applied BEFAST, you would have identified that they had balance and vision problems, the stroke would have been identified and they'd have been referred through to the stroke team. Now, the imaging for this patient on the CT angiogram reveals that they had a basilar artery thrombus, which is a really not a diagnosis that you want. It's one of our most serious strokes. FAST itself misses approximately 40% of posterior circulation strokes, where BEFAST saves lives. So I've got two different outcomes for this patient. The first one is after we've applied FAST. So no one noticed that this was a serious stroke. He wasn't referred to the stroke team for assessment. He never regained consciousness and he sadly died. And this is a picture that used to happen and probably still does at times. This is why we need to be more vigilant and apply that BEFAST test. Outcome 2. The triage nurse applied BEFAST and alerted the stroke team immediately. The patient was given clot-busting treatment and had a mechanical clot retrieval, so a thrombectomy. They were discharged home on day 3 to live a full and independent life with the family. So just the difference between applying two simple tests is the difference between life and death sometimes. BEFAST does save lives when it comes to posterior circulation strokes. Clinical scenario 3. A 72-year-old female reports sudden loss of vision on the right side. Symptoms started 3 days ago. No drooping, no limb weakness, speech was intact. Apply the FAST test and then apply the BEFAST test. So here we are again. Sorry, I've copied and pasted that for us wrong. FAST test was negative. BEFAST has identified some eye problems. The patient's scan actually showed that, so the examination showed that she had a right homogeneous hemianopia, which is loss of vision on half of each eye. CT angiogram showed a left posterior cerebral artery occlusion. The MRI confirmed an occipital lobe stroke infarct, so caused by a clot. Unfortunately, because she was 3 days down the line, she couldn't have any reperfusion therapy. So the pure visual field loss wouldn't be detected on FAST, but is captured in BEFAST. So the clinical scenario outcome was the emergency department receptionist applied BEFAST and recognised the symptoms of stroke. The stroke team was informed immediately. The patient was not eligible for reperfusion treatment. Rapid identification and referral did, however, mean that the patient had some early imaging, early diagnosis, and early treatment plan. We optimised her risk factors early, prevented complications, and she had earlier access to therapy and earlier discharge. This patient was discharged on day 2 with community stroke team and referral to the orthoptist. And finally, clinical scenario number 4, 77-year-old male. While having coffee with his neighbour, he suddenly vomited and developed a right facial droop, left arm weakness and slurred speech. He was unable to stand and complained of double vision. If you can just apply those tests again. So this patient he was FAST positive and he was BEFAST positive. Both tests in this situation would have picked up some key red flag. CT scan did confirm that the patient had an acute hemorrhage in the brainstem. His outcome, the triage nurse applied BEFAST and alerted the stroke team immediately. The CT scan was performed, which showed the brainstem hemorrhage. They were transferred to the stroke unit. They did actually have the ABC ICH protocol initiated, and we did lower his blood pressure, but he didn't have anything to reverse, and he was referred through to neurosurgery, but there was no intervention. So this is just a little bit of a breakdown in terms of what we've found for each of our cases. So case 1, we had a positive FAST and BEFAST, which showed the left middle cerebral artery stroke. Case 2 had a negative FAST but a positive BEFAST, and it picked up the basilar artery thrombus, which was because it had balance and eye symptoms. Case 3 was a negative FAST and a positive BEFAST for vision and picked up on an occipital stroke. And the last one was both FAST and BEFAST positive and highlighted a brainstem hemorrhage. So just to summarise, really, stroke doesn't always look dramatic. It's very often the symptoms are very subtle, and it might be just somebody who's got a little bit of a facial droop. But if somebody suddenly seems different, confused, unsteady, or complains they can't see properly, it's important that you trust your instincts. If something doesn't feel right, it probably isn't right, and getting help immediately can make that critical difference for our patients. Using the structured stroke recognition tool like BEFAST it gives us a more reliable way of recognising our stroke symptoms. We know that standard FAST can miss up to 40% of the posterior circulation strokes, which often present with problems such as balance and visual disturbance. We know that time wasted is brain lost. For every minute of strokes left untreated, 1.9 million brain cells die. So we should be making that early referral. And we know that early recognition leads to timely treatment and better recovery. Your actions might save a life and prevent a major disability. And I think there's just one more last slide. What we need from you, particularly in identification. Identify the stroke symptoms using BEFAST. Ask if the stroke symptoms started suddenly. What time did the symptoms start? Or when were they last seen? Or have they woke up in the night? Refer immediately through to the stroke team. This is not a tool for diagnosis. This is something that we'll take forward as a stroke team. So if you can do that, we'll take it from there. Just get the patient referred through to us quickly. There's a million references there, which you can't see because they're so small. I could only get them on one slide, but I'm sure if you want to have a look, you can have a look when the slides are sent through to you. And just if anybody's got any questions. I'll have a little look now through the chat. Robin, did you want to say something? I'm just scrolling.
Hi Linda, it's Claire from the East Lancs Stroke team. Thank you for your presentation. It was really
Hi.
Thank you. Hi. I was just wondering, obviously in terms of the BEFAST, I think it's really helpful having those extra additional symptoms added on. But when they did the FAST kind of assessment, there was a massive public health campaign to help educate the public around the FAST symptoms. And I just wondered if there was any kind of plans or if anything has been done to sort of support educating the public around the balance and the eyes part of the BEFAST, because I think in terms of getting people into hospital and capturing those strokes early, potentially these posterior strokes are the ones that we can potentially miss and can be quite mild, and the symptoms might not be, they might not know that it's a stroke symptoms at the moment to get themselves to hospital quickly. And was there any plans to do any kind of public health awareness around the extra additional symptoms that have been added?
As far as the Stroke Association is concerned, I'm not really sure. I don't think they are planning on changing the campaign. I don't know whether Elaine can add to that.
Linda, can you just repeat the question? Sorry.
It was just around whether or not the public campaigns are going to change over onto BEFAST from FAST to increase awareness of posterior circulation strokes. As far as I'm aware, there's no plans to do that. Did you know anything different?
No, recent conversations with the Stroke Association said that they've talked about it, and they're looking at wider models, as like Claire mentioned, I suppose. But no, nothing else has come.
No, I know when I've got a patient in the hospital, and which is probably kind of dealing with the horse after it's bolted, I will safety net my ambulatory patients using BEFAST. So I do use BEFAST to safety net my patients. And I think we'll probably do something a little bit more locally around that, but nationally, I think the FAST campaign is staying as it is for now, I'm afraid. Does anybody else have any questions? I can't see anything obvious on the chat. You know, I think the key thing is this is just a stroke recognition tool. This is about early identification to get these patients through to the stroke team, getting maybe the ROSIA done by the emergency department, allowing us to do the National Institute of Health stroke scale. It's just kind of the gateway to further assessment tools rather than a standalone tool. I think if there's nothing else, then I think we will close the meeting, and thank you so much for your time.
Thanks, Linda. That was really great.
Thanks.
Brilliant.
Thanks, Linda. Superb.